Hi, I'm Dr. James Goldstein from Beaumont Hospital. I'm Director of Research and Education, and I'm going to present some work we're doing on a novel complete radiation protection system designed to allow operators to work without ever getting radiated and obviating the need for orthopedically burdensome lead aprons. It's a system that's been manufactured and will be sold by Image Diagnostics Inc. of Fitchburg, Massachusetts. It's called the Protego Radiation Protection System. I was involved with the development of this, and we licensed it to Image Diagnostics, so I have a conflict of interest. It's I think well known to everybody working in the field that the interventional laboratory poses workplace hazards, particularly those related to radiation and also those related to the ergonomic aspects of working with lead on your backs and bent over the table for hours on each day and over a period of years. And that present available systems widely used are those kinds of limited shields that have been around for decades and have not evolved significantly, which is what is presently used in most labs. They provide incomplete protection to leaving the arms, the legs, and the eyes, at least the brains anyway, unprotected. The eyes are partly protected, but still there's a very high incidence of cataracts, as I'll discuss, as well as cancers related to radiation. The one that's well established are the risk of cataracts, and there are multiple studies that have shown over the years that working in the fluoroscopic suite, whether it's cardiologic or interventional radiology or other, leads to a threefold higher risk of cataracts, posterior cataracts that get under you, even if you're wearing lead glasses in exposed individuals. There's also concern over brain cancers and skin cancers, of those are less well established. But what is well established is the epidemic of orthopedic injuries that many of us have suffered, some leading to curtailment of work hours or even careers. And as I'll show you some data from some wonderful studies published, the incidence of spine-related disease is 50% in those who've been working for 10 or 15 years, and hip, knee, and ankle problems, 30%, and it's caused loss of work at up to 30%. And it's in great part related to the bearing of orthopedically burdensome leaded aprons, and also to the fact that interventional cardiology has changed what we do over the past 25 years to more complicated cases, higher procedural volume, and particularly us baby boomers, more years worked. This is a study from the Mayo Clinic published in JACC in 2015 that looked overall at their institutional workers in the Cath labs, comparing those who actually worked in the labs where they're in harm's way exposed versus 500 people unexposed. And they found that 50% of those working in the lab wearing lead had orthopedic injuries, and it was related to age and number of years worked. And it was not just physicians, by the way, it's nurses and techs as well. This is another study published in Circuit Cardiovascular Intervention in 2016 that looked at similar issues of orthopedic and other non-orthopedic health risks in Cath lab workers, and they stratified it by job position and number of years worked. And they found a very significant incidence, again, of orthopedic injuries, also cataracts. Frighteningly, there was a statistically significant difference in cancer, as well as skin lesions, some of which were cancers. So radiation is bad. Bearing the burden of orthopedically burdensome lead is, on a daily basis, even worse. So there's an unmet need. How do we mitigate these Cath lab occupational injuries? We need to eliminate operator, staff, and radiation exposure. We shouldn't have to work hour by hour, day by day, month by month, year by year in an environment where we're getting radiated. It doesn't make sense. We have materials that block radiation. Surely there must be a way to format them in a way that we can completely protect ourselves, never get radiated, and eliminate the need for orthopedically burdensome lead aprons. So I've been working for some years on a system to do that. And here are some of the, what we call critical to quality elements of a design system. CTQs, it has to eliminate operator radiation exposure, or at least dramatically reduce it, but reduce it enough so that it obviates the need for wearing leaded aprons. There must be no interference with procedural performance, of course. There's got to be full access to the patient for vascular access, catheters, and of course the back table for equipment. One has to be able to have full fluoroscopic cine visualization, not only of the heart, but appropriate vascular access sites and the catheters. There has to be unimpeded motion of the C-arm in the table. And there has to be minimal, optimally no operator manipulation of the shields during the procedure so that we can focus on what we do, not just the protection. It's got to be easy setup and rapid case turnover. The system that we have finally developed that is about to be marketed, called the Protego radiation shielding system, consists of an upper shield above the table and a lower shield that integrate with patient drapes. The upper shield is designed in a beveled fashion, so it passively accommodates CR motion, accommodates the full envelope of CR motions, even in the most extreme caudal angulations. There's a central aperture on the upper shield through which the patient sits on the table. This goes over the patient's groin area, or at least hip area. It allows for the patient to lay on the table comfortably and for vascular access, both radial and femoral. This upper shield is suspended from a support arm that is either on a mobile base or can be suspended from the ceiling. It has multifaceted articulations that allows facile panning at the table. There's a lower table shield that integrates and overlaps with the upper shield. And there's an interconnect patient drape that then completes the full three-part radiation protection system. And there are vascular access apertures, which can be covered with sterile drapes as well. This is a comparison of the computer model on the left I just showed you with the clinical model that was tested at Beaumont by Dr. Simon Dixon on the far right. Been working at testing this system and looking at radiation results. Here's a close-up of the clinical system. Again, it's the upper shield with a bevel designed to allow complete C-arm angulations. It has leaded acrylic windows to allow visualization of the patient as well as the C-arm by the operator. As the overlapping lower shield. This is the floor-based pedestal with a suspension support arm with multifaceted articulations. There's the interconnecting patient drape. And there's vascular access both for radial, brachial, as well as femoral bilateral. And this is just a demonstration of how the bevel design of the upper shield accommodates the angulation of the C-arm. This was not an easy task to accomplish, and this beveled C-arm does not require any operator manipulation. It allows full angulation without having to manipulate the shield whatsoever. We were very focused on making sure there was optimal visualization of the patient and the C-arm so that the upper shield contains these windows that allows the operator standing next to the shield to see every aspect of the patient's head as well as the C-arm and its motion. And again, this is a demonstration of the access sites for both the radial brachial as well as the femoral sites. This system has been tested at Beaumont Hospital in a preclinical setting by an independent radiation physicist. And the finding was that the shielding exceeded that provided by 0.5 millimeters of lead, which is the legal standard for leaded apparel that we wear. And wasn't just the body that was protected in the traditional apron sense, but the entire envelope downstream from the shield was protected. So that 0.5 millimeter lead protection is afforded to the entire operator's body. In fact, the primary operator, secondary operator, and any nurses or tech standing on the downstream side of that shield are totally protected. So there's a potential for a paradigm shift for cath lab health and safety, a new approach for not just operators, but also the staff who are in the lab every day, the nurses and techs who are getting radiated and have to bear the burden of those leaded aprons and lifting patients up and have a high predilection to orthopedic problems. So it's designed for total body protection, mitigates the operator radiation risks and need for lead aprons. It has a small footprint, no operator manipulation is needed. It's minimally obtrusive and easy to operate. Simple deployment and sterile draping, ease of use in case turnover is quite rapid, less than 5 minutes. The benefits are afforded, again, not just to the physicians, but also a full cath lab staff, at least at any time they're downstream and not having to go up to the patient's head. So that we believe it'll translate into improved safety and health for the entire cath lab team. Don't have the full cost data yet, but we believe it'll be reasonable, competitive, and applicable to radial and femoral cases. And this is the system that'll be ready for clinical sales in the upcoming months. We transition from a blue to a white to make it transparent in the cath lab and fit in a nice ambiance way for comprehensive total body shielding, obviates the need for lead aprons. Thank you.